everyone, and welcome to Ovarian Cancer Australia's Information and Support webinar. My name is Vanessa Alford. I'm part of the support team at OCA. I'd like to begin by acknowledging the traditional owners of the land that we're on and pay my respect to elders past and present. This webinar is supported by an educational grant from Roche Products, for whom we are extremely grateful, especially during these challenging times. We're so grateful that we can continue to provide resources and support our women. The focus of this webinar will be on the latest developments in ovarian cancer. We have three incredible presenters who are going to share some valuable information with you. The webinar is interactive, so over the next hour, you can ask questions to the presenters by using the dark blue hand icon at the top of your screen. Questions will be answered at the end of each presentation. Please note that the presenters cannot address individual medical cases. If you do have a question, please call the Ovarian Cancer Australia Information and Support line on 1300 660 334. This webinar is being recorded and will be posted on the Ovarian Cancer Australia website. For technical assistance during the webinar, please phone Redback Support on 1800 733 416. So I'm extremely privileged to introduce our presenters to you. Our first presenter is Professor Michael Friedlander. Professor Friedlander is Conjoint Professor of Medicine at the University of New South Wales and a medical oncologist at the Prince of Wales Hospital and Royal Hospital for Women. Over the course of his career, he has had a leading role in gynecological cancer clinical trials nationally and internationally, and has co-authored 400 publications and received numerous awards in recognition of his contribution to gynecological oncology. He has been closely involved since 2007 in the early and late phase trials of PARP inhibitors in ovarian and breast cancer. In this webinar, Professor Friedlander will talk about the current role of PARP inhibitors in ovarian cancer. Our second presenter is Dr. Yolan Antle. Dr. Antle is a medical oncologist and cancer genetic specialist at Frankston Hospital, Royal Melbourne Hospital, and Cabrini Health. Her interests are in the management of breast and gynecological cancers. Dr. Antle is involved in the development and conduct of clinical trials and has published over 30 papers in international journals. She has more than 15 years' experience in both medical oncology and in the diagnosis and management of hereditary cancer syndromes. In this webinar, Dr. Antle will focus on germline and somatic genetic testing in ovarian cancer. And our final speaker is Kristen Young. Kristen was diagnosed with stage 3C ovarian cancer in September 2009 and has been on clinical trials for much of that time. Kristen hopes that raising awareness of clinical trials and research will lead to more women benefiting from new treatments the way she has. In this webinar, Kristen will share her experience of being involved in clinical trials and what it has meant for her. So I'd now like to hand over to Professor Michael Friedlander. Thank you, Professor Friedlander.
Thank you very much for the introduction, and hello to everyone out there, and hope you're all doing well and in self-isolation. I'm going to be talking about PARP inhibitors in ovarian cancer, and I'm going to try and talk without the distraction of the echo that is coming through, which is difficult, but nonetheless I'll do my best. I've sort of been working in the field of PARP inhibitors for about 13 years, and I think without sort of exaggerating, I think they really have made a big difference, and hopefully will continue to make an even bigger difference as time goes on. What I'm going to try and talk about in the next 15 minutes is just really give you a general overview. I'll firstly try and provide some insight as to how and why PARP inhibitors work. I'll talk very briefly about a concept called homologous repair deficiency. I won't go into great detail, as I know Yolande will be talking about this as well, but this is just one of the mechanisms whereby cancer cells repair DNA damage. And it's critically important because it explains why many cancer cells, in particular ovarian cancer cells that have this deficiency, are more sensitive to PARP inhibitors and indeed also probably to chemotherapy as well. And we'll talk about the relationship between BRCA mutations and PARP inhibitors. And then I think it's important to have a few definitions because we use terms like progression-free survival and median progression-free survival quite loosely. And it's important that people understand what we're talking about when we use these terms because many of the clinical trials are reported in terms of progression-free survival. And I want to just go over that briefly. And then I will discuss what the recent trials have shown and focus on maintenance therapy in particular because I think that's probably the most important emerging role of PARP inhibitors. We also need to discuss the downsides of treatment, and as you will all be well aware that all the treatments we administer and prescribe do have potential benefits as well as potential side effects, and these are important and can impact on quality of life. And then at the very end, I'll talk about where we're going with PARP inhibitor research. The fatal flaw in breast cancer mutated cells is a deficiency in DNA repair. And this indeed leads to the increased risk of developing cancers in people who've got BRCA mutations, but also makes them exquisitely sensitive to PARP inhibitors. So this, for me, is really a very, very good example of a targeted therapy because it's targeting a specific deficiency in a tumor cell and without necessarily affecting normal cells. Obviously, there is some collateral damage, which we'll discuss in a moment, but essentially it's targeting the tumor cells. The development of PARP inhibitors has been really, really rapid. I know 13 or 14 years doesn't sound like a long time. It sounds like a very long time, but in fact, in the development of new drugs, it's actually a very short time. So only really in 2005, there were two, what I would call seminal critical papers that were published back to back in one of the most eminent journals called Nature that demonstrated that BRCA tumor cells, these are cell lines, were exquisitely sensitive to PARP inhibitors, whereas tumor cells that did not have a BRCA mutation did not appear to be affected by the PARP inhibitor. And those two papers changed the way we thought about ovarian cancer very, very rapidly. And within a year or two, the phase 1, the very early development studies started with PARP inhibitors. And over the last 13 or 14 years, there has been very rapid progression through what phase 1 to phase 2 trials, where we tested PARP inhibitors in women with much more advanced recurrent ovarian cancers. And when we found that there was benefit in that situation, then we moved on to the maintenance setting, and I'll talk about that in a lot more detail. But hand in hand, or coincidentally, with the development of PARP inhibitors, our knowledge about BRCA mutations, our knowledge and understanding about the biology of ovarian cancer, and specifically the fact that not all ovarian cancers are the same, and how in particular BRCA mutation carriers are very sensitive to PARP inhibitors, and we also recognized and understood that tumors that had deficiency in repairing DNA, so-called HR deficiency, were also very sensitive. And that sort of changed the way we thought about using these drugs. But before moving on to that, there's just some very fundamental basic concepts. I have simplified them, but I think hopefully we'll get the message across. So if we consider a woman who's got either BRCA1 or BRCA2 mutation, something she's inherited, in other words, she has a germline mutation, what that means is in every single cell of her body, she has a normal copy of BRCA1 or 2 and a mutated or non-functioning copy. And that's reflected in the diagram that you can see in the slide. So one copy is mutated and non-functioning, and one is functioning. So in that cell, BRCA function to some extent is retained, and the main role of BRCA is to repair DNA damage. So those cells still have the ability to repair DNA damage. Now, when a cancer develops, in the tumor cells, there's no functioning BRCA. So in other words, there's a mutated BRCA that's been inherited, and the other normal, inverted commas, BRCA gene has either been lost or mutated. So in the tumor cell, there is loss of function. There's no BRCA gene that is functioning, and the protein that these genes produce is not present, and this results in disrupted, abnormal DNA repair. And because these cells cannot repair DNA damage using the normal mechanisms, they rely on backup mechanisms, which are not particularly effective or good, and this explains the sensitivity to PARP inhibitors, as shown on the next slide. So on the left-hand side, you've got your BRCA function, and you've got your technicians who know how to repair the damage. On the right, you've got your backup crew who come in and help repair the damage when your main crew are not available. And so in a normal cell, when you treat with a PARP inhibitor, we know that normal cell can still repair DNA damage because it's got a normal functioning BRCA gene, and those cells are not affected by a PARP inhibitor. And in a cancer cell that has lost BRCA function, it relies on the PARP enzymes to repair DNA damage. So this is the backup crew. And if you inhibit that particular enzyme with a PARP inhibitor, in other words, get rid of your backup crew, then when DNA damage occurs, it cannot be repaired and the cell dies. It's sort of as simple as that. I know it's kind of oversimplified, but essentially that explains why PARP inhibitors work on BRCA-related cancers, and also you'll see in tumor cells that exhibit this deficiency of homologous recombination repair. Because this is also a very important mechanism whereby cells repair damaged DNA. And so BRCA mutations are a very good example of faulty DNA repair, but there are many, many other mechanisms other than BRCA mutations which can also lead to this repair deficiency, and tumors with this homologous repair deficiency are more sensitive to PARP inhibitors. And this allows us to try and work out who should be treated with a PARP inhibitor. Now, I'm only talking about ovarian cancer, but PARP inhibitors work in many other cancers as well. So we know that not all ovarian cancers are the same. Indeed, there are many, many differences between different cancers, and even within the more common or the most common type of ovarian cancer, which is called the high-grade serous cancer, there are multiple variations and variants, and we know that about 50% of high-grade serous cancers have a deficiency in DNA repair. And of those, about maybe 15% or so have BRCA mutations. So those are the tumors that I'm going to be more sensitive to PARP inhibitors, and the ones that will benefit from treatment or potentially benefit. So now I'm moving to definitions, because you need to understand these definitions when you're reading the results of clinical trials. The way that we measure benefit, and I think it is controversial, but nonetheless this is the way we do it, is looking at what's called progression-free survival. And this measures how long patients live without evidence of the cancer growing or spreading while on treatment, compared to the group of women on the control or placebo. And we measure recurrence using CT scans, which we do every 3 months or so. And if there's evidence that the cancer grows back or increases in size, or the patient develops symptoms of progression, that is then termed progression, and that's how we measure progression-free survival. And then what we report in clinical trials is the median progression-free survival, which is the length of time from the start of treatment that half of the patients have not progressed. So that's really important to understand, because it helps interpret the results of trials. So when should we use PARP inhibitors? And they've been looked at in a number of settings, and I'm going to talk about them each briefly. Either as treatment alone in women with recurrent ovarian cancer, and that's where we first started using PARP inhibitors in clinical trials, or as maintenance therapy after response to treatment in women with recurrent ovarian cancer, And more recently, we've been looking at PARP inhibitors after first-line chemotherapy. And the current generation of clinical trials that we're doing are combining PARP inhibitors with other drugs, immunotherapy drugs, angiogenesis inhibitors, and so on and so forth. So there are lots and lots of trials going on at the moment. So the initial trials focused on women with advanced recurrent ovarian cancer, often who'd had multiple lines of treatment, and we were able to show that PARP inhibitors did appear to work, and they worked much better in women who had not had a lot of chemotherapy and also had what was called platinum-sensitive recurrent ovarian cancer. The side effects appear to be less than chemotherapy, but in general, the duration of benefit was measured in months. And it was clear that we could probably do better than that. And from then, we came up with the concept of maintenance therapy. And this is based on a number of basic principles. First of all, that almost all women who have been diagnosed with ovarian cancer, who have had a good response to chemotherapy, will unfortunately relapse after stopping chemotherapy. And the duration of remission will get shorter with each line of chemotherapy. And on average, the duration of remission is usually less than 6 months. It can be a lot longer, but the median is around 6 months. And although further chemotherapy can be offered, the chance of it helping gets less over time. So the question was, if we gave PARP inhibitors after response to chemotherapy, could we prolong the duration of remission, and could we perhaps prevent the cancers coming back at all? And the first study that we did was called Study 19. And this included women who had had often many lines of chemotherapy and had responded to or re-responded to chemotherapy, and they were randomized to either get olaparib or placebo. And there was a striking difference in the median progression-free survival. It was almost a 3 to 4-fold difference in favor of the PARP inhibitor. And what was also striking was that about 16%, I know it's not a lot, but it's something that we hadn't seen before. It's really a substantial change. 16% of women on that particular trial were still on the PARP inhibitor without evidence of progression for over 5 years and continued on treatment. And that study then led to many, many other trials, which I won't go into great detail, but they summarize very briefly here, because essentially they all showed the same thing. And these trials demonstrated that, in particular, in women with BRCA mutations, there was a 3 to 4-fold longer duration of remission or delay in progression in women who were randomized to a PARP inhibitor. And that was seen in these 3 different trials using different PARP inhibitors. Most of the women who had BRCA mutations appear to have the greatest benefit, but even in the women who did not have BRCA mutations but had tumors with the repair deficiency, the so-called HRD deficiency, there was also a benefit, supporting the role of maintenance therapy. But the real ultimate goal is it possible to increase or improve overall survival in women with ovarian cancer? In other words, once and done. So if you have chemotherapy and you go onto a PARP inhibitor, is it possible to prevent these cancers coming back? Now, that is the holy grail, but ideally, if we want to improve survival, probably the best chance is after initial treatment. And there have been 4 trials that have looked at the role of PARP inhibitors. The first one was called SOLO-1, and in SOLO-1, women with advanced ovarian cancer, after they had completed chemotherapy and responded to treatment, were then randomized to either olaparib or placebo. All these women had BRCA mutations, and it was called a 2-to-1 randomization. And what that trial showed very briefly was a very significant benefit in favor of olaparib. And at 3 years, 60% of women on the olaparib were progression-free compared to 27% for placebo. So a doubling in the progression-free survival. And we have limited follow-up. So Time will tell whether this treatment actually means that a higher or larger proportion of women will remain disease-free without recurrence. But this has really been quite transformational, and the important thing is that there were 3 other trials, similar but different, that were reported late last year. I won't go into great details apart from saying that they all also demonstrated that PARP inhibitors improved the progression-free survival, a very significant improvement, particularly in women with BRCA mutations, but also in women with tumors that had homologous recombination deficiency, suggesting that we can potentially change the natural history, if you like, of this disease. And this just shows you very briefly some of the findings. For example, the progression-free survival was more than 2 to 3-fold longer in women who were randomized to a PARP inhibitor. I won't go into great detail because of time. I'm going to move now onto the side effects of PARP inhibitors because that's very important. There are differences as well as similarities between all these PARP inhibitors. The most common side effects are nausea and fatigue. The nausea comes on pretty early, but usually, not in everyone, in most people, will improve within 4 to 8 weeks. Fatigue can be persistent and can be a long-standing problem for some women, for sure. Other side effects include vomiting, constipation, diarrhea, and altered taste. And anemia is the most common abnormality on blood tests and needs to be monitored for carefully. An important, but fortunately very rare side effect seen in the PARP inhibitor trials has been leukemia in about 1% or so of people. Now, this can also occur with chemotherapy in the absence of PARP inhibitors, but it's important to be aware of this, and we're still trying to learn a bit more about which women are more likely or susceptible to developing that very serious side effect. Regular follow-up is very important with clinical review and regular blood tests. And this slide demonstrates when these side effects occur. And as you can see, most of the side effects occur quite early with nausea, vomiting, and anemia, all tending to occur in the first few months, but can occasionally occur later. But it's generally in the first couple of months, and once you've got through the first few months of treatment, then things are usually okay for most, not for all people, but for many people. About 25% of women will require dose reductions, and sometimes we have to have dose delays and dose interruptions. So very briefly, PARP inhibitors, I think, have earned a place in the treatment of women with ovarian cancer. The greatest benefit we've seen has been in women with BRCA mutations, but non-BRCA-related cancers also respond, and the real challenge is to identify who these patients are and to work out what the best tests are. The greatest benefit appears to be with maintenance therapy after response to chemotherapy. Time will tell whether we can improve survival. There are side effects of treatment which require careful management, and the next frontier is combining PARP inhibitors with other drugs in the hope that we can change the outlook for many women with ovarian cancer. And I think I've gone a bit over time, and I'll stop there. Thank you very much.
Thank you very much, Professor Friedlander, for that valuable presentation. So much information there that will benefit us all. There's been quite a few questions, so I do apologise if we don't get to your question, but I will just ask a couple. The first one is, what is the current advice on the age that women who carry the BRCA2 mutation should have their ovaries removed to prevent ovarian cancer?
So I'm going to leave that to Yolande because she's going to talk about that in her talk.
Okay, fantastic. Another question, has there been an opportunity for oncologists to talk with drug companies about whether patients should or should not be taking PARP inhibitors if they contract COVID-19?
Oh, look, that's a really, really good question, and I think no one really knows, and I think it's something we have to be aware of and careful of. Probably the greatest risks in people who contract COVID-19 are age and other medical problems. We don't really know whether PARP inhibitors will make things better or worse. I'm certainly not make it better, but I don't think it'll make it worse. I think they're different to chemotherapy. So the answer is I don't know, and I don't think any drug company knows that answer either. But it would be prudent for anyone on any treatments to self-isolate and do whatever they possibly can to avoid getting COVID-19. But I'm sorry I can't answer that question because there's really no data on it.
Sure. Thank you very much. We will let you go, Professor Friedlander. Thanks again for joining us on this webinar.
Okay. Thank you. Bye.